Are there any other thoughts you have on how you might foresee individualized titration becoming standard practice?
Yeah, we have now 6 registered drugs available. We have other drugs in the pipeline. That means we have a huge armamentarium of medical treatment in CML. Therefore, I think the discussion with the patient, what are your treatment goals? Is your treatment goal just to survive without side effects? Or is your treatment goal treatment-free remission? Is your treatment goal to achieve an optimal quality of life? Is so important. And we should start this discussion after diagnosis immediately when we select the first-line therapy and inform the patient what are the options, of course. When we only introduce one drug and provide this drug, that's not shared decision making. We should introduce the shared decision making in this process, starting at diagnosis, but going step by step to involve the patient into the treatment options and into the decision making in the therapy. This will improve the compliance of the patients, and this will improve quality of life, and finally, of course, efficacy.
Yes. Are there some ways that we haven't discussed that you see maybe Enliven's role evolving in the CML treatment algorithm, especially for patients with multi-TKI resistance or intolerance?
You ask for Enliven. Since this is phase 1 only,
Mm,
I think that's an important question, but too early.
sure.
I would ask this question for Asiminib. Yeah, it's because Asiminib is registered in third line and in the US and Switzerland and other countries also in first line. I expect and I hope that my colleagues will agree on that Asiminib should be used in a majority of patients in first line because it's efficacious, it's well tolerated, but it should, of course, demonstrate a long-term effect on the quality of life. Therefore, it's important to measure this and to show a major step. I see this major step in the revolution of CML therapy, since it's more expensive, of course. Any new drug is expensive, and we need to consider, of course, economics here. But if we see a major improvement and can stop the treatment eventually in treatment-free remission, then we reduce the overall costs again.
What are your thoughts on combinations or potential combinations with allosteric inhibitors in earlier lines of therapy? And what patient populations do you think this would benefit from this strategy?
Yeah. Um, Asiminib was developed initially as a combination therapy because it inhibits a different site. It binds to a different binding site in BCR-ABL, the myristoyl binding pocket compared to the ATP binding pocket. Therefore, it was obvious to try a combination between ATP competing drugs and Asiminib. This had been implemented into the phase 1 trial with different dosages, different drugs, but was compared to the monotherapy as well. And it was obvious that the tolerability of the combination is less good than the tolerability of the monotherapy. And the efficacy was not much better with the combination than with the monotherapy. Therefore, for the phase 3 registration trial in third line therapy, ASSEMBLE trial, Asiminib 80 milligram per day monotherapy was chosen and was compared to bosutinib in this case. And then eventually in the first line trials, Asiminib 80 milligram was compared in the Ask for First trial to all the standard of care drugs available, and in the Ask for Start trial compared to nilotinib. Overall, these trials demonstrated the advantage for efficacy, but also for tolerability. And therefore, I think the translation into clinical practice is that Asiminib is the best available drug for first-line use.